Good afternoon, ladies and gentlemen, and welcome to today's Healthcare World Series event. Well, we'll be talking about the global digital health agenda. My name's Steve Gardner. I'm the Managing Director of Healthcare World. I'll be joined today by an outstanding panel from all over the world to discuss where we are in terms of the development of digital health, probably the most, well, definitely the most important development in healthcare in the 10, 12 years that I've been working in the international healthcare sector. The reason we're doing this today is because in 2 weeks' time, all of the people I'm going to be joined by today will be joining me in Chicago for the HIMSS Global Gathering, the largest gathering of digital health professionals anywhere in the world. And I'm delighted to say that we're going to be joined by HIMSS President Hal Wolf for the keynote interview at the beginning of this session, and then following that up with a discussion and a debate with some really, really interesting people from around the world. I'll introduce them as we get to the session. So digital healthcare. For me, reflecting on this morning as I was thinking about this session, what's fascinating is the way in which digital healthcare has pushed itself to the forefront of our thinking in healthcare around the world over the last sort of 10 or 12 years. When I first started working in this sector, digital healthcare was something that we knew was coming down the track. We knew it was going to be important, but perhaps we didn't realize quite how important it was going to be. There's a saying that I'm going to paraphrase probably quite badly around the fact that we overestimate the things that will make a difference to our lives in a year and underestimate the way that they'll make a difference to our lives in 10 years. And I think if you look at the way in which population health data is starting to influence our thinking and the way in which we look at preventing the need for interventions in care, we probably couldn't have predicted quite what an impact that was going to have on us 10 years ago. We probably certainly can't understand just how much it's going to change things in the next 10 years. The other reflection from my point of view is that the COVID pandemic has obviously changed the way in which we think about digital health and changed the way in which we use digital health. We've moved now, I think, from a situation when I first started in this sector where the intervention that was required around any healthcare problem globally started with the building of infrastructure, the need for more doctors, the need for more face-to-face interventions, to a situation where the theatre of healthcare has moved from the hospital and the surgery to the home, or potentially to the home, more and more so over the last few years, and that will continue to be a change. My final point before bringing Hal in is probably to think about this from the point of view of the logic of the situation. If you think about the idea that what do we do with sick people? We send them to a building full of more sick people. There's a fundamental lack of logic in that. If we can treat people in the home, if we can reduce the number or the amount of time that people are spending with doctors and in interventions in clinical settings, surely that actually helps us to achieve some of the goals that we have in healthcare, healthcare prevention rather than healthcare cure. And with those thoughts, I want to bring Hal Wolf in. Hal, as president of HIMSS, I know we've talked about some of these things before when we've had discussions. I guess I want to let's start with HIMSS itself. Explain to us what HIMSS is, what its mission is, what its history is.
Sure, I'd be happy to. And first of all, thank you for having me, and thank you for all of the participants today. It's an honor to be on this panel, and it's an esteemed honor to be able to lead off. HIMSS is a global society. It was started back in 1961 with an idea of some professors at Georgia Tech University in Atlanta that we could use computers to look at data in order to improve health outcomes. Crazy talk, as we would have called it back in 1961. What a novel idea. And really start to look at the information in terms of how it is able to bring itself forward. And from that beginning, HIMSS grew into a society, first in the United States and now globally. And today we have over 122,000 members across the globe with HIMSS, which is effectively a global advisory organization. It supports critical thinking. It builds maturity models that people are able to follow, which are a culmination of years of observations and work by our members all across the globe to figure out what's the best pathway from point A to point B. And it's a environment where people get to come together and actually talk to each other about the challenges within their own local system, within their own geographic area, and also on a global basis. Is there are many things that are very universally applied overall, no matter where you are in the world. Our mission is very simple, which is to reform the global health ecosystem through the power of information and technology. And this is fundamentally driven from a vision statement, which is to realize the full health potential of every human everywhere. So, sitting behind our core values is health equity, which is one of the major themes this year of HIMSS in Chicago, which we hope everyone will be joining us the week of the 14th in Chicago of April. So we're only a couple of weeks away. So this is really wonderful timing in terms of that opportunity to be together. And from a global standpoint, over 450 organizations will be represented. So HIMSS is really at the forefront of digital health and always has been. There was an old poster a long time ago by Ted Turner when he talked about CNN, and he used to say, we were cable before cable was cool. I think, at HIMSS, we kind of look up and say, we've been digital health before digital health was cool. So, that's where we are today.
I mean, I talk about digital health being a small part of our agenda 10 years ago. I think the forefront to think about it back in the 60s and to see the potential of digital healthcare at that point is really quite a remarkable thing. So obviously, we're all going to be in Chicago in a couple of weeks' time. Why is that particularly important? Why is it important to bring this community together? And what are we going to be discussing while we're there?
Yeah. Well, first of all, you nailed it earlier. The global conference is without question the preeminent conference in the world where people who are focused on digital health and the use of information and technology and how it impacts our entire ecosystem. This is the largest gathering where people come together. And it is a global conference. We have more countries represented this year, over 40. We have the largest delegations we've ever had from around the globe coming to Chicago, and of course, a very good base in North America as well. So this is the one place that for a whole week, besides the parties and besides the components, this is really a meaningful discussion around strategy, around policy, a glimpse on the exhibit floor of what is available and also what is coming. And most importantly, the ability to run into people and talk to people and network and have serious side discussions, whether formal or informal, about what is impacting them and how they move forward together.
So what are the key themes then? What are the things that we need as a community to be sitting down and talking about in terms of the development of digital health in the coming years?
Well, I think Steve, you started touching on it, really well. So if we take just a half step back and we take a look at the challenges of the global health ecosystem, they have not moved much in the last 5 to 6 years. And that's maybe good news or bad news, but we're making some dents in it. So the first is we still have an aging population. Thank goodness, I'm a part of it. We all are to that extent. But now we have an aging population of the baby boomers, which are living longer and expect a better lifestyle than they had previously. And because they're living longer, they wind up with more disease burden. And that's just the nature of it. And we're a heck of a lot better at diagnosing disease burden. We are dealing with geographic displacement besides the chronic care that needs. And geographic displacement, by the way, is not just rural. There are far too many people that live in the shadows of outstanding and amazing hospitals, but they do not have access. So the ability to gain access is really what we're talking about when we start talking about geographic displacement. And we are completely overwhelmed now from a challenging funding system. There is not a country in the world, including Norway, that isn't looking up now and saying, oh gosh, we've got some financial challenges on our healthcare system. So this continues to happen. And then we get to the real crux of the matter with digital health, which is a lack of actionable information. And that is getting better, but we still have a very long way to go. And we'll be talking about that a lot in Chicago and how that information ultimately gets used because of the challenges within AI and other areas. And then we have a massive staffing shortage. To your point about people, inevitably, I feel sick, I need to see a doctor. There's a huge gap. So 5 years ago, when we were looking at the data from the WHO, they were predicting at that time, or stating at that time, they had about an 8 million person gap on the clinician side. And we're projecting that by 2030, there was going to be about a 13 million person gap of clinicians in order to take care of people based upon the classic encounter-based paradigm. Today, the WHO, and I've talked to the individual who does this same estimate, is now projecting anywhere between 18 to 20 million in terms of the gap on a global basis. So the point of the matter is that we simply are not able and will not be able to continue with a paradigm of an encounter-based environment, right? One-to-one type of move. And what that means and the ramifications of it is that solutions like telehealth, which is nothing more than a digital representation of one-to-one, that isn't going to cut it either. I mean, you can get smaller sessions and it's quicker, and it's far better for the individual to be able to do something from their home than a 3-hour journey there and back to a particular hospital. But that's not the challenge. The challenge is, how do I get individuals with the proper coverage and the old adage of getting them in front of the right person at the right time? So there's a premium that's coming, and it's already here, but there's a premium about the face-to-face encounter, and digital health is an amazing way to supplement that.
So let's delve into that one a little bit more, because I think that's, you're right. I mean, that's an absolutely key issue that's coming down the track at us very, very quickly. I think it's also worth mentioning that certainly in the UK and a number of countries around the world, we also have an issue around attrition amongst healthcare workers around the world in this kind of post-COVID world where people have been worked so incredibly hard. It's that gap is getting bigger. But what can digital health actually do outside, as you say? I mean, the idea of doing face-to-face consultations through a computer, that's fine, but that can't solve the problem on its own. What other solutions are there out there that can help mitigate this workforce crisis?
Well, I start with the very basic premise of what healthcare is. And again, it touched back to some of your opening comments, which I appreciate. I think about healthcare when I worked in conjunction with so many physicians on the front line in the word anomaly. And what that means is that each and every one of us, have fundamental standards of what is the norm for us, or what is the norm for us as it exists against population health targets and standards. And what happens when an individual doesn't feel well, or something is going wrong or different outside of the norm, is an anomaly. So what we do is we bring a lot of people in, our patients, citizens, however you wish to label them. And by the way, they wear all three hats simultaneously. If you're sitting in the exam room, they're a consumer. And that's the last part of the challenge, is that everyone is now a very demanding consumer, and they're getting so even faster. They're a citizen, they have expectations of what's going to occur and the services afforded to them, and they are also patients. So they have some need that needs to be done. And we bring in someone who's not feeling well, or we have someone, what we're trying to do is identify the anomaly. What is different than what would be in the norm? And we do a lot of testing, and we do a lot of outreach, or we wait for the patient to come in. What digital health allows us to do, and the applications that are being developed, is to proactively anticipate what is an anomaly that an individual may have, or one that is coming. And we can catch it earlier on a preventative basis in order to get them on a care pathway. And that's what we do. When we identify an anomaly and we can define it, we start treating someone. And if we can't define that exact anomaly, we keep testing them until we can. But that is what we do in healthcare. So the identification of the anomaly away from the clinic, the use of digital health applications, this is where we're beginning to see a lot of use of information in conjunction with personal data. that allows us to develop applications to proactively anticipate or hierarchically prioritize the treatment that an individual should get at the right institution at the right time.
So essentially what we're saying here is that we can use digital healthcare to make our health systems more efficient by ensuring we're getting people straight to the right treatment at the right time without the kind of necessity for them to go back and forth into a physical setting, to be prodded and probed while we try and work out what we're trying to do for them. Does that kind of summarize the journey that we're on and what we're trying to achieve?
I think so, and it goes a step further. So, in many studies around the world, and it's been done multiple times, we know that healthcare at the point of care really impacts only about 10% of a person's medical condition. Personal health, their personal behaviors, the genomics that they bring into the shop that they're born with, those two factors alone are roughly 70% of what impacts a personal healthcare of an individual. Then you have lifestyle, you have social determinants of health. These are where components of health equity and access to care is so critically important. So by the time you're done, there's about 85 to 90%, depending upon the study, of healthcare impact which is taking place before an encounter ever occurs. So our ability to use digital health to proactively get ahead on an individual, to help them in lifestyle, to help them on preventative services, again, trying to stay away from that anomaly, this is where we can make a huge difference. And this is what we're seeing. This is why people are tracking individuals the way they are. And even in the most basic situation of a village somewhere that does not have normal access, a simple 3G EMR, if you would, or medical information with bio tracker that can just give the immunization record of an individual is a huge step forward. It's massive impact on maternal health. It is massive impact on the health of a society. And let's call it out. A healthy society is a healthy economy. And so this is not just about healthcare or the health of an individual. It has an impact of the health of an entire community.
Well, there's a couple of things that you've talked about there. That latter piece there, we've always had that understanding of the relationship between health and wealth. If you look at lower income countries, one of the key drivers of their economic development should always be quality and access to healthcare. You also sort of talk there about the idea of, not treating the sick, but simply stopping them from becoming sick in the first place. And there's a point that I want to raise with you there, which you nodded to when you were talking about the themes of HIMSS, which is, yes, we can do preventative healthcare. Yes, we can do predictive healthcare using genomic data, using medical records, using probability, using cloud computing. But actually, you're actually widening the problem rather than making it smaller. Instead of looking at that small subset of people who are sick and treating them, you now need to broaden this out and look at the whole population. That's a data problem, isn't it? How do we get access to data at the kind of level that would allow us to find an individual who maybe hasn't been to the doctors in a few years or whatever, and say, hey, you need to come in because you are at risk of an issue? How do we get to that point?
Yeah, so there's kind of two or three layers to what you just said, and they're all extraordinarily valid. What we learned during the pandemic is, of course, we have really poor ability to quickly gather the information that we need to assess the situation at a population health level. Prior to the pandemic, we were collecting information and it fundamentally trailed the population on a good day by several months. And then suddenly we wound up in a situation where we really needed to know by the day, if not by the hour, what was fundamentally happening in our hospitals, and we were lost. Our data collection systems were just very, very poor. Now, let's go back and be realistic. Data itself is completely useless. All data is ones and zeros that are sitting inside a server. That's all a data is. Turning data into information, now that's important. because then we start to group that data and we start to have something we can compare. And when we compare it, we get knowledge. And when we have knowledge, we can come up with solutions and information that allows us to create clinical utilities, which allows us to build apps. So what's fundamentally happening now is this development on the back end, which is very positive in many ways, around the cloud-based lake environments that are collecting data on a large scale. Now, the danger point there is one point of failure. And of course, everything has to be done with the strictest level of cybersecurity and to protect the individual. But it also allows us at the same time to have collective information, which allows us to understand and identify challenges that are there. When I can do that, I can create applications that allow an individual with the most basic information of their immunization, their age, their fundamental demographics, a little bit of knowledge of their social, that an individual can plug into formulas at their request or the request of their physician or the approval of it, which can help then identify these anomalies or the anticipation of them on both a preventative and a situation where I've got to identify the anomaly and put them on a care pathway. So we have to have access of two different things. One is access to a back end that contains those applications built upon larger scale data. So we've learned and created knowledge. And then second, the individual has to have those little tiny bits of data on their own that allow it to plug into the machine, if you would, come out with the right answer or recommendation that helps any clinician, whether it's a nurse, physician, et cetera, to make the next move. And this gets back to this gap on the clinician side, by the way, and then it's going to raise a really critical point, which is scope of practice and recognizing that we have got to be broader and wider, to your point, about who has access to that information so that we have better capability of helping the individual no matter where they are.
So here's a controversial question for you, Hal. We have all sorts, we're talking about a global gathering of digital healthcare professionals in Chicago in a few weeks, all of us coming from different jurisdictions. I want to get into the difference in payer models and how we pay for digital healthcare in a moment, but let's stick with the data theme for now. Every country has its own data legislation, its own data privacy laws. I guess the first question for me is, though data privacy, the ability to manage your own data as an individual, choose what it's used for and what it's not used for. In terms of digital healthcare and the population health ambitions that we have, are those privacy laws friend or foe? Are they stopping us from getting access to the data at the level that we need in order to make these predictive models? Or are they a good thing because people's data could be abused or used for the wrong purposes? I wonder what your thoughts are.
Yeah, so the answer to your duality question, because you asked two of them, is yes. You know, on one hand, we have to do what we are doing to rationally improve and ensure that an individual's personal data is not used against them. This is really what we're trying to prevent. You know, my data is my data. There's nothing more personal. Think about what we go through to try and secure components of our financial data, and health data is even more personal. At the same time, we use general de-identified data to understand the health of a population and the person next to you. So if every individual locked down their own information and refused to share it, then we would be nowhere. We would not have population health. We would not have the ability to generate larger scale information. We would not be able to create utilities that are built to help the individual. So there's an interesting balance here between the rights of the individual and, frankly, the needs of society in general to take care of large groups of people, and then the benefit back to the individual. So I'm a huge, huge believer that my personal data and information needs to be identified, and it needs to be in secured locations. I'm also educated enough, and by the way, most of the public isn't, so that's not a slam. We look at this every single day, so we're going to have a slightly different point of view. But I'm also exposed enough, might be a better way to put it, to recognize the value and the need of aggregated de-identified data on a large scale basis. To your point about individual countries, this is what keeps me up at night. So during the pandemic, we shared a lot of information, and boy, did we make a lot of progress. We were able to identify where the pandemic was growing, where it was shrinking. We were able then to identify when we brought the public sector and the private sector together to solve the pandemic, which it took both, by the way, where vaccines were working, where they weren't, and what we needed to do, how were lockdowns on society, which was designed to take pressure off our healthcare systems, impacting what we were doing. All of that was because we were sharing information. Now, prior to that, a lot of countries had rules that said, the data just can't leave here. That gets very restrictive. And the idea that somehow the borders of a country stop a virus from crossing, those myths are dispelled. So if we're not smart enough to recognize that we have to have data sharing across borders for the good of the societies in which we live in, then we're really going to be in trouble. And I think people recognize that. It's just an important balance, to your point, that we're going to have to continue to debate and walk. But I do think we're heading in the right direction.
So a couple of points on what you just said. Going back to the individual and their data, firstly, how much is this an issue of education? You said in your reply that a lot of people don't understand. We have a different lens because we look at this every day, but the general population don't have that understanding of what data is being collected, where it's being shared, and what it's being used for. How much then is there an issue here about the general population understanding why it is good for their data to be shared in this way?
Yeah, Steve, it comes down to leadership, and I'm sure that our panel has multiple views on this point. But look, when you look at a general population, emotion generally overcomes logic in nearly every scenario around the world. So people look to leaders to keep the emotion down, which can always be flamed up. The point of this, of the leader in the healthcare ecosystem, is often the clinician that an individual is working with on a daily basis. So the understanding of our physicians and our nurse practitioners and our clinicians talking to each individual where that contact takes place, and describing for them not necessarily the greater good, but how individual applications with their information could in fact save their lives and why it's important to them, has a huge step forward in helping them understand how their information, de-identified and secure, then helps their next door neighbor. There's an old expression that says all politics is local, and I assure you that all healthcare is very local as well.
But at the same time, the second part of the answer that you gave some moments ago was this point about globalization. And I share the frustration. We made so much progress during the pandemic at individual country level and globally in terms of sharing data, the speed at which we started to embrace digital healthcare solutions, the speed at which we developed the vaccine program. And yet it feels like we've gone backwards again. And life has gone back to normal without really kind of any thought. Do we need to think more globally in terms of the way that we adopt digital healthcare solutions, and how would you do that around between countries and regions?
Well, let me push back a little bit on the premise that everything has gone back to normal. It really has changed in many ways dramatically. So before the pandemic, we had less than 1% of the individuals in the world using telehealth and applications in conjunction with their physicians and their clinician environments. At the height of the pandemic, it was nearly 20%. Right now, it's settled in around 8-9%. And those numbers change a little bit, but it's a pretty significant difference. So I think that there's that piece. The second part is the awareness of our consumers. I'm using the word consumers at this point in particular, because when health services were cut off almost nearly completely in the first year of the pandemic in order to deal with the ramping and the fundamental challenges that we had, individuals suddenly learned they could use telehealth. They started turning to it. So there is a global app ecosystem that is being developed at rapid pace. I mean, you can't turn the corner at HIMSS coming up in Chicago. You can't turn the corner almost in any discussion that's taking place where there's not a new application that has popped up and it's solving for a particular problem, and they're almost being built to scale, so they can be integrated into the ebb and flow, if you would, outside in from an information standpoint. So I think it is changing pretty fast. Just to get back to that really critical premise, the question is how fast can they get the information, to your point earlier, and drive forward.
You talked earlier on in the conversation about health equity, and we've talked about how digital healthcare could potentially, I'm sure this is a theme we'll come back to, how digital healthcare can help us towards the goal of ultimate universal healthcare around the world. You've also very kindly invited me to chair a panel in Chicago in a couple of weeks, where I'll be comparing health systems and payer models from around the world, from at the one end of the spectrum, the US health economy, where it's so very insurance and cost driven, down to the UK's universal health coverage system with the NHS, two completely different ends of the spectrum, which personally I think every health system in the world sits somewhere on that line. The question for me, though, is when you start thinking about those different health systems and the different payer models within them, healthcare is a business like any other. It all comes down to money and who pays for it. So my question, Hal, is this. It's all very well having a digital health revolution, but how will it be paid for in individual health systems?
Yeah. Well, first of all, your point about the healthcare systems is exactly right. We're all over the place. I used to live in London. I was a member of the NHS, if you would, or a patient of the NHS, and I appreciate that system so much. And have spent many years working inside the NHS, either living there or outside, and thinking about its redesign and what it means. And there's a huge challenge there financially, right? Which is just overwhelming the system finally, because you just can't squeeze it and starve it and then expect it not to have an impact. So we can talk about that one on a regular basis in just a few minutes. But I think that when you sit back to your main point and you start looking at the difference that digital health and how it's going to be paid for, let's recognize what we're trying to do. Digital health can be used strategically to reduce the strain on my current workforce. It can expand the reach of a healthcare system without building brick and mortar, which is extraordinarily expensive. So I'm not sure that it reduces ever the cost of a healthcare system, but it reduces the cost of taking care of its expansion to individuals who before were challenged to gain access, and has the ability to improve the outcomes of individuals who do have access by, again, getting preemptive or being able to identify those anomalies earlier. The problem we're all going to face, and I brought this up in my very first list, is this challenge funding ecosystem. We have to find better efficiencies, at the same time balancing it against the health equity components. We're getting into that quad aim, the triple aim, that everyone strives for. Just a small note on that. When the original triple aim, which was created, was brought out, Don Berwick's view was not that all three were supposed to be achieved simultaneously. The point he was trying to make was that there were three competing elements between outcome, cost, patient experience now brought in, et cetera. And you had to find a balance. Only healthcare would have taken what is a push and pull situation and say, oh, we'll do all three simultaneously and equally. It just doesn't work that way. I mean, it's very, very difficult. I think it's altruistic to try and think of it. But to be able to afford everything for everybody at one time, it's a great goal, but it's not the way it will work in the end. To the point saying this, and please bear with the concept, health equity in its purest form is not achievable. There's always stuff that's going to happen that is going to create inequity. Our true north is health equity. And so as long as we stay focused on that, we will do a better job today than we did yesterday. And we also have to recognize that it's never perfectly achievable.
I mean, it's a really good point. I mean, at the end of the day, if you look at cost and outcome, they are slightly mutually exclusive. There are, you can't necessarily improve outcomes without increasing costs. There's a balance between the two, sure, and absolutely we should be aiming to increase both. But it's a very difficult thing. You look at the two out there examples of health systems. You've got a commercially based healthcare system in the US where cost is let's like the UK first, where actually you've got a universal healthcare system, costs increase and increase and increase all the time, and the whole thing becomes unsustainable. Then the US, where you've got a commercial health system where the imperative to reduce costs in order to create a better business model, how does the relationships are they kind of got to fit together.
The only thing I would say there, Steve, is we don't actually have a healthcare system in the United States. We don't. The NHS is a healthcare system. The United States does not have a system.
Well, the United States is a healthcare market.
It's a healthcare market, and it's a good way to look at it. And it's not working. I mean, it's just getting worse and worse by the day. On the other hand, which is really interesting, is that over 50% of healthcare now in the United States is paid for by the government. So whether people recognize it or not, we're shifting more towards that type of a system where the government is already the main provider of care, not physical care, but of the funding of care. And it's putting an impact on both the prices, the identification of anomaly, and all the components we've talked about. So the United States is shifting, but the United States is an absolute formula for imbalance.
I mean, at the end of the day, the UK isn't far behind at the moment. At the end of the day, it's a really interesting paradigm when both healthcare systems are fundamentally broken. We have a situation in the UK where we have industrial action, we have issues around pay, issues around conditions that have all come about because of the amount of strain that the budgeting of the NHS has placed on its workers. So if both ends of the spectrum are broken, how do you find something in the middle that works? Well, if you want the answer to that, I suggest you come to my session on Wednesday at HIMSS.
There you go.
Where we'll have a whole bunch of leaders from different systems around the world debating the good bits and the bad bits. I want to bring the rest of the panel in a moment. I've got one more question that we can't have a conversation about digital healthcare without mentioning the I word, interoperability. Ultimately, we've got so many different solutions, so many different ideas and technologies. How the hell are we ever going to get them all to talk to each other?
Yeah. Well, first of all, interoperability has been one of the core elements that HIMSS has worked on for years, both trying to facilitate in the definitions of interoperability and where we go. And interoperability used to be just purely the semantical components of how we exchange data and information. But we also talked today about organizational interoperability. How does the information even move across a single domain? Where you can have continuity of care, and that interoperability has to occur as well. Look, here's the competing elements, to be perfectly direct. We have a desperate need, and we have for a long time, for data and information to be exchanged easily and with a consistency of format. It's why wonderful organizations like HL7 exists, IHE, and other institutions which help the exchange of that information. Competing against it is the proprietary and private sector that believes that by the unique use of its information and how they exchange it, that it gives them material advantage in the development of applications. Until we get to a point legislatively and from a regulatory standpoint that dictates, then it's going to continue to be a mishmash. That being said, and the capital market being what it is, there are organizations that have been developing, if you would, Rosetta Stones that sit in the middle for that exchange. So it really comes down to a choice, open source or proprietary, the need, and there's a lot of discussions, of course, and agreements that have been built slowly but surely, but we need to move faster, or the fundamental exchange of information. At the very least, it's semantic integration, meaning, of course, that, a rose is a rose by any other name, would help us dramatically. And we did that during the pandemic. We stripped down the definitions very quickly in terms of ICU capacity and definitions around the individual. We can do it. It's just a question of the design and the push. And it's going to have to come from the top, because it won't come organically from the system itself. The systems of the healthcare ecosystem are fundamentally designed for interoperability not to exist. And yet the need of society is for it to exist. And so that will also be a critical debate that you'll hear pop up in several locations, all across HIMSS in 23 in Chicago.
And before I bring the panel in, when can we catch you at HIMSS? Are you going to be on stage?
I'm going to be on stage multiple times. In fact, it's a little daunting, but I really hope everyone is there by Monday at the latest. There's a lot of great exchange starting on Sundays, actually, with the pre-program. And then the big part of the program kicks off Tuesday morning, and it's going to run right through. I'll be on stage with some amazing people. I jokingly always say I'm the eye candy, because when I have to contribute with all these amazing brains around me, just like the panel we're about to have, I wilt in the background because there's just so many incredibly impressive people that are going to be participating. So it's just looking forward to it. This is going to be fantastic. I'll be there Tuesday afternoon, by the way. I'll be with Glenn Tolman, and we're actually going to be tackling this idea of insurance companies and what role do they play in the US system, and how that needs to change and how it is changing. And that has a lot to do with the reimbursement component that you mentioned earlier. So I'm looking forward to that view from the top. Wednesday, Thursday, and even Friday, there's just going to be some amazing discussions. And we're looking forward to your panel, of course, on Wednesday. That's just going to be amazing. It's going to be great.
It's going to be fun. I look forward to sharing a drink with you when we get to Chicago. If you could hang around for us, Hal, and also take part in the panel, that would be fantastic.
I'd be honored. I can't wait to hear the rest of the group. I'm excited.
So let me introduce then our broader panel, and we'll go around them for a bit of a view on some of the things that Hal's been talking about in a moment. To introduce in no particular order, it's just the order that are on my screen, quite honestly. It feels like the World Cup of healthcare. We have, representing the United States of America, Ernesto Chinona from CSSI Life Sciences, who is a regulatory specialist and market entry specialist in the US. Drew Ivan from Rhapsody, interoperability specialist, who I'm sure will be weighing in on the last point that I made there. Representing the United Kingdom, we have Vincent Buscemi. Don't be fooled by his accent. He may be from the States, but he's been in the UK for a long time. At Lawyers Bevan Britton. I'm sure you'll have a few things to say on some of the data privacy issues we were talking about. Phil Anderton from ADHD 360, who is coming to HIMSS this year for the first time, and we'll be talking to about his work in countering ADHD and how mental health can be looked after online. Representing Northern Europe, we have Bjorn Almer from Sweden, from Scanacare. Representing the Swedish government, also will be joining me at HIMSS. And last but absolutely not least, the amazing and brilliant Mwenya Kasonde, representing Africa, former advisor to the Minister of Health in Zambia, global healthcare consultant. And I think, Mwenya, you've probably worked for just about every major international healthcare organization that certainly I can come across, all the kind of big names that you would know. I want to start, guys, by going around each of you. You've just heard, I think, an absolutely fantastic précis of where we are globally in digital health at the moment. Just want to ask each of you individually to reflect on what you've heard from my conversation there with Hal, from your own perspectives. Mwenya, perhaps I could start with you. I mean, I know you've been working on digital and data initiatives in Africa. I don't know how much you can say about that, but where is digital health in Africa at the moment, and what are the key concerns there?
Great, thank you, Steve. Thank you for having me, and thank you to Hal for such a wonderful intervention. I'm looking forward to joining you all in Chicago in a couple of weeks' time.
Well, you'll be on my panel.
Wonderful, I look forward to it. So this has been such an interesting conversation, and I wonder if I actually have any more to add to it, because just so much has been said already. But one thing that really struck me, in what has been said so far, is really the focus on being more people-centered. The WHO's global digital health strategy actually very much advocates for people-centered health systems that are enabled by digital health. And so for me, and to sort of answer your question, I think where we really need to make a clear link is between investing further in digital health and health outcomes. There needs to be a link with the SDGs. This is an interesting year for us this year. 2023, you probably know, marks halfway to the Sustainable Development Goals of 2030. So we're halfway there. And of course, we've been delayed by the pandemic. We've got plenty of lessons learned over the last few years. What are we going to do differently, and how are we going to get there, by 2030? So really linking that investment in digital health to achieving the SDGs and specifically leaving no one behind. One of the things, I think you know this about me, Steve, that I worry about, of course, is, broadening that gap by, forgetting some of the issues that we need to address when we are trying to accelerate progress, and perhaps leaving some of our colleagues behind, specifically referring to fragile states, small island developing states, etc. Specifically in Africa, I mean, we know that that is the most affected continent in terms of poor health outcomes. Nearly half the world's population actually still lacks access to essential health services, and most of them are based on the African continent. Fewer than 50% of Africans have access to modern health facilities. In many African countries, spend less than 10% of their GDP on healthcare. There's a great shortage of trained healthcare professionals. So we appreciate that we can certainly use tools such as those that are available to us through digital technology to accelerate much of the progress that needs to be made. At the same time, 42 out of 54 African countries have national digital health strategies in place. So we're all thinking along the same lines, we're all having the same conversations, but very few of those actually being implemented. And that's where it really becomes a missed opportunity, and it really becomes a bit of a shame. I think we need to consider some of the challenges, of course, that exist on the continent, lack of awareness and knowledge about digital health and the power of digital health. Also, issues like poor infrastructure just simply cannot be ignored. The lack of power and connectivity in some of our areas, poor internet connectivity, lack of interoperability, you've mentioned that I word, quite a few times. So we still have some challenges that are stopping us, from getting as far as we would like to be right now. But nonetheless, we realize the power that is in our hands with many of these platforms. And just to conclude, I think for me, again, I sort of come from a data angle. As you know, I've been doing a lot of work connecting digital health and data. And I think that's where, for me, the magic happens almost. I think being able to use digital health to give us information, to give us data, is really where we become very, very powerful. And digital health, keeping in mind, enables the entire data journey. So it's not just the collection of data, it's the cleaning, it's the storage, it's the visualization, and of course, it's the use of data. So that means we collect information once and use it multiple times. And it also means that we move information and not people. I'll stop there for now, Steve. Thanks.
Yeah, I mean, there's some really interesting thoughts there. I mean, it's really shocking, actually, that we're halfway through that program of getting to the UN Sustainable Development Goals. You made the point quite rightly, delayed by the pandemic, but even without the pandemic, the goal of the fundamental goal of universal health coverage for all citizens all over the world, it seems like we're so far away from that. I guess what I wanted to ask in follow-up there was, for Africa in particular, Hal and I were discussing payer models and how digital healthcare will be paid for. Given, and I remember when we've done panel sessions before, you've absolutely shocked me to the core when you've told me the proportion of spend in a lot of the less wealthy economies of Africa, the proportion of healthcare spend that comes from government as opposed or traditional payers, whether that's government or private insurance, and the amount that's coming from aid funding. Is there a particular problem in Africa about how digital innovation is paid for? And is there any solution on the horizon to that?
Yeah, absolutely. I mean, we can't sort of deny the fact that many of our healthcare systems are still donor funded. They're very much reliant on sort of external donor funds. And specifically in this digital age, I think it creates a very, very difficult problem in the sense that one of the challenges that we have is that many donors come in with their own systems. I think we had a report from the Ministry of Health of Botswana at one stage where they were complaining of 35 different electronic health systems in place to serve one country and one ministry, which simply isn't viable. You can't have 35 different, electronic health systems in place. It's just not going to work. So unfortunately, at the moment, we're struggling with a situation where indeed different donors are coming in, but not just that, they're coming in with different systems. And many of the time, these systems indeed are non-interoperable. They're not speaking to each other. They're duplicative and they're just not efficient. And I think the simple sort of, the simplified solution to that is really, I think, the need to empower many of our people as Africans, as African leaders. And Steve, in my opinion, the true power comes when you can say no. When you are empowered enough to say no, thank you very much, but I don't want an additional electronic health system for my Ministry of Health, and that's when we can really start to move the needle and see change in the system.
No, it's completely agree with that, and no less of an authority than Dr. Nicholas Crisp, the Director General of the Ministry of Health in South Africa, a friend Mwenya of both of us, who's worked across numerous sub-Saharan African economies. I was lucky enough to talk to him in Johannesburg in November of last year, and he actually made exactly that point, that donors will obviously want to decide what their money is going to be spent on, and actually we need to be empowered to say, actually, no, we don't. That's not what we need. What we need is this. Actually, and in digital health, as you rightly point out there, actually saying yes to multiple systems that don't talk to each other is counterproductive. It takes your healthcare backwards instead of forwards. Really fascinating perspective, Mwenya. Thanks very much for that. Vincent, want to move on to you. Obviously, UK, very different set of circumstances. From what you've heard so far from Hal and Mwenya, what are your kind of particular reflections? What do you think the issues inherent are from a UK point of view?
Thank you, Steve, and thank you for inviting me along today. It's a privilege to be here and to speak with you and your listeners, viewers, and other panelists. And like others, I really look forward to coming out to Chicago in a week or so, 2 weeks' time, I think it is. So yeah, here in the UK, having heard what Hal said, and there's a lot of things that resonate here in the UK. And for me, it was all about the sort of capacity, access, and integration agenda that we're struggling with in the UK. We do have our problems in terms of the NHS at the moment, and where the NHS is headed in terms of the challenges that it is facing, whether that's post-pandemic issues or the seasonal spikes in demand, the backlogs in elective surgical lists, and congestion surrounding discharge from hospital for those who are medically fit to be discharged, but there's a lack of long-term care packages or the ability to assess and fund those, and so people stay in hospital longer than they need to be. All that soup, if you will, of issues superimposed on that, with funding problems both on the health side as well as the social services local authority side, the lack of individual carers and clinicians, and the shortages that we've got in workforce around recruitment and retention challenges. All sort of, for me, mean that sort of digital solutions that can assist healthcare providers and caregivers to monitor and manage patients safely at home, that's high on everyone's agenda at the moment. And whilst the terminology may not be universally agreed, and whether we're talking about virtual wards here in the UK or hospitals without walls or remote care, I think the core concepts of extending the reach of clinical and multidisciplinary staff out of the bricks and mortar facility of a hospital to liberate time and space and allow patients to benefit from access to care and treatment from the comfort on one hand and the familiarity of their own home is what we're talking about. And these models, whatever they're called, invariably involve elements of remote monitoring using apps and different technology platforms, wearables, and other medical devices. And they could, of course, be supported, as they are from time to time here in the UK, with face-to-face care from multidisciplinary teams that are based in the community. Is the direction of travel I think we're going to see more of in the NHS. But pushing up against that, we often hear a lot about, and I think, we focus a lot on the potential risks that are associated with the adoption of technology in these new delivery models. But, for me, those risks need to be balanced against the efficiencies in the way that care can be provided, the savings financially that can be made, and the clinical outputs, patient experiences that can be improved by the use of technology, because there's numerous risks associated with inpatient care, and those risks themselves can be minimized through remote care models, such as the reductions in risks associated with infection or infection control, muscle wastage, pressure sores, general deconditioning, the sorts of things that happen to people when they're in hospital, and largely being treated in accordance with a sickness model rather than a sort of wellness model. So I think remote monitoring and wearables and data transfer platforms that securely allow clinically reliable data to be passed from patients to treating healthcare practitioners without the need for face-to-face care is certainly going to be an attractive model for the NHS providers, for independent sector operators who are supporting the NHS, but also for the funders of these services, whether they're the government through the NHS, whether they're local authorities through social services, whether they're insurers through PMI, or those individuals who are funding their own care, the self-funded. All of that is, of course, against the backdrop of the two I words, I'll call it interoperability and integration, because we do have interoperability issues and concerns here in the UK because of the wide range of digital health solutions that are on the market. How do they all talk to each other? Within the NHS, you've got individual elements of a single hospital trust that can't talk to each other, let alone one hospital to another, or NHS organizations to care homes or to people's own homes. And that links to the whole concept of integration between health and social care, and how true integration can occur without, a very rich care record that's supported by electronic patient record systems, because most providers that I speak to, whether they're in the NHS or whether they're in the independent sector, say that for true integration to take place, regardless of government policy or funding, that becomes almost impossible without a shared care record. And so I think we need to see some cultural change and a move from NHS bodies further forward around collaboration rather than competition, improved resources for patients, to enable these sharing of data to happen across the hospital system, across health and local authority systems, and then with other caregivers, the individual themselves, their families, their insurers, etc. So I think there's a lot that Hal has said and a lot that Morena has said that I think really rings true here in the UK. Same problems, different system.
And broadly, you know, have we got the right ideas? Are we going in the right direction as a digitized health system? You know, we're the oldest free at the point of delivery health system in the world. The NHS is 75 years old. This is a big deal for the UK to try and digitize that health system. Are we doing the right things? Are we thinking in the right way?
Yes, I think we are. I think we've identified what the challenges are. I think there's lots to be done in terms of addressing those challenges with funded solutions. I do think that the latest reorganization of the NHS that took place, earlier this year, we're starting to see the cultural change that is needed, where NHS bodies are, of course, moving away from being competitors to collaborators. We're looking now at system-wide working through the integrated care systems led by integrated care boards. There's ongoing and better communication between NHS organizations and local authorities because they form part of that integrated care system. And the debate has moved on beyond the use of the independent sector as being something that is bad to something that can help and support the NHS. And it ought not to be forgotten that, the independent sector support to the NHS, not only through the increasing capacity framework, which is designed to address some of the backlog in elective care, but the NHS has always been effectively a public-private partnership since it was created. And in that respect, I think those debates, those discussions are moving on. It's now around the way in which technology is regulated. And of course, there's not a one size fits all model for that. And, the speed of regulation and the speed at which regulators and government policy can move in these areas to make data sharing and to make a truly rich electronic patient record system that goes across the whole of the health and social care ecosystem, it will move slower than the technology will advance. And so ultimately, it seems to me we're heading in the right direction, but we have a lot of work to do in order to get to where we need to get to, in my view.
And how much of the issue is funding and infrastructure?
Funding is a perpetual problem in the UK in the NHS system. I can't remember the exact figures, but we're talking about a budget of just over £100 billion, and there's still not enough money in the system. The consequence of that, of course, is that we can't do everything all at the same time. And I think it was Hal who earlier said, in healthcare with the triple aim, everybody, try to do everything all at once, all at the same time. I think part of digital health and the use of medical technology to provide services in different ways is about creating positive disruption and moving quickly and breaking things. Unfortunately, with that goes the need to fund these things in a way that is sustainable and supports equitable and universal access to health and social services, but also to create the infrastructure that's needed. And I mean that the technical and regulatory infrastructure rather than the bricks and mortar, because I think, it's ironic for me that at the same time as we talk about virtual wards, we here in the UK have a hospital building and rebuilding program that wants to build 40 new hospitals and redevelop a bunch of hospitals. So, where is the money being focused? Is it being focused on the bricks and mortar and the technology, or is one being favored over the other? Because in many patients' minds, as you said earlier, Steve, we still have this idea that when I'm sick, I should go to a building, whether that's the GP surgery, whether that's the hospital, rather than I'm not well, maybe these services should come to me. And so I think that takes a cultural shift in thinking rather than just a governmental policy shift.
I think you actually end up with a political way of thinking, and it's interesting. I mean, it harks back to Mwenyu and some of the work that I've done in Africa. Something that governments always love to do is cut a shiny ribbon on a shiny new hospital. It's so much easier to kind of demonstrate value to the people. But look at this big building that's got my name on the front, rather than, let's look at investment in allowing people to access healthcare in a more convenient, easier way from home. That's always kind of an issue all over the world. And unfortunately, I suspect that hospital build program is exactly that. It's an example of old style thinking. Let's go from one end of my extreme to the other. How different is the picture that Vincent has just painted of the UK's development around digital health and Esto to what you see in the US?
Thank you, Stephen. And I thought that this conversation has been quite fantastic. What really resonated with me from the conversation with Hal is really the transformation of data into information, into knowledge, and then into something like an application that can be used. Currently, it's no secret that the U.S. healthcare system is fundamentally based in the private sector, and there's a belief by a large portion of the population that it should remain in the private sector, but that may change. It's kind of hard to foresee, given that there are certainly benefits to a government-based system. But thinking of the U.S. as really not a system, but like you guys have mentioned, it's a market. It does pose certain advantages to especially emerging digital health companies. If you think about who ultimately your customer is as an innovative company, it might be a little easier to think about the variety of payers and the variety of hospital systems as potential customers, and so then you have perhaps many and a diverse population that you can address that may be interested in your digital product, and that changes slightly when that customer base is perhaps reduced slightly to a handful of kind of government-based decision makers. And so what's inspiring to a lot of these emerging companies who I talk to all the time is the fact that they can leverage the fact that the customer base currently is diverse and it's big, and that helps de-risk some of these technologies, especially in the eyes of investors. And so because the investor then feels perhaps that they may be able to get the return on the investment if in fact the company is able to successfully exit into a private healthcare market. Because at the end of the day, just like you mentioned, it is about who's paying, and it is about the money. And so and the U.S. system kind of really affords that. So that's kind of at the market level. At the actual company level, what's really interesting is that what I see are kind of three main buckets of digital health companies that are really eager to enter the healthcare market here in the U.S. The wellness apps that are really currently focused on kind of the individual, the layperson consumer, and keeping them informed, perhaps helping them with preventative measures of disease. Apps that are then the second bucket's really apps that are catered to physicians and healthcare providers, but those that really just provide that initial kind of first step of the conversion between data and information. And one I think challenge that a lot of these emerging companies are facing currently is how do we integrate the data that my application is providing into kind of the healthcare protocol of an American physician, given that one hospital system is going to be dramatically different from a different hospital system from a private clinic, because they may work incredibly differently in terms of how they adopt technology, how they pay for technology, and what their individual priorities are. And kind of the third bucket is those apps that are really software as medical devices. And really taking the next step in converting that information into knowledge and perhaps suggesting a diagnosis, perhaps suggesting a course of action, certainly higher risk technologies. But what's exciting is that those higher risk technologies have a chance in making it in the U.S. market, because there are champions for kind of that next generation, whether it's AI based or machine learning based, those types of technologies that perhaps a privatized healthcare market might be able to better absorb than a public single payer system. And so that's what I see currently.
It's a really interesting perspective, actually, Anessa. You're almost saying that the strength of the American healthcare system is its very weakness, is the fact that you don't have a health system. You've got a disparate group of providers spread across the whole country, but actually that fuels innovation in its own sweet way, because you have a market of different organizations and different companies that want to do things in different ways. Have I kind of paraphrased that in the right way?
Absolutely.
Yeah, and I guess, Drew, that kind of brings me on to you guys. So Rhapsody, of course, what you do is you solve, or you try to solve, this interoperability problem. The description that Ernesto has given of the US healthcare system, is that why your organization has grown out of the US, because of the need to be able to adapt from one healthcare provider to another across such a broad landscape?
Yeah, I do love the framing of the US healthcare system as a market, because once you look at it from that perspective, everything else that's happening here makes perfect sense, right? That's why we're spending more every year, because markets grow. That's what they do. Ernesto has it exactly right. It also fuels innovation, but that comes with a cost. From my perspective, all of these digital health applications, or even the traditional IT applications like an electronic health record or billing system, they all need to be fed data. Each system takes data as its raw material and does something with it. They turn it into workflows. They turn it into information and insights. They turn it into whatever it is that application is intended to do. Starts with getting the data in, and that data is generated from some other system. And so that's the driver for interoperability. There needs to be this method for starting that process by getting data into the application. I think what the challenge we see is that the types of data that we're talking about are constantly changing and growing and improving. One of my favorite examples is social determinants of health. That's something that, today there are standards for expressing data about social determinants of health, standards for transferring that data. Those standards are not well adopted yet. But if you look back 5 years, or, especially if you go back further, 10 years, we weren't even talking about social determinants of health. And, that's an example of the reason that interoperability will never be finished, because, today we have pretty universal adoption of certain types of interoperability, like electronic prescriptions. Those are quite common everywhere. But, once we have that done and adopted and flowing well, we'll move on to the next type of data, like social determinants. And there's not a way to transfer those around. And as it becomes useful to move that data around, then we see a fresh interoperability problem emerging. And so I think of interoperability not as a single problem to be solved and accomplished and moved beyond, but rather as something that goes along with all these other problems we're solving. It's almost like an example I sometimes use is road work. If you're going to have roads, you're going to have road construction, and it's never going to go away, because you always need to maintain them and improve them and keep them up to date with the different types of traffic and the different destinations that you're trying to get to. Same thing with interoperability. It's part of the infrastructure, and therefore it's always going to be under construction. So That's the perspective that we're coming at this problem from. We know that everyone who's engaged in developing digital health has this problem of how do I get the data that's going to be my raw material, and we're trying to solve that problem for everybody so that they don't have to solve it for themselves.
It's interesting, actually. I feel like you stole my analogy. I've used that one a few times. The idea of healthcare, particularly, it's the way I often describe integrated care as being the idea that you dig up the road once and you put the sewers in and the broadband and the electrics and the gas mains and the water pipes and do it all in one go, rather than having to dig up the road multiple times. I guess what gets kind of interesting there is the fact that interoperability, it's kind of the same thing. It's how do you integrate between the different levels of the health system. If you're going to have integrated care, you need to have interoperability between the layers of the health system. Am I thinking about that in the right way?
Yeah, we think about interoperability at many different levels. There's interoperability between devices and software systems. There's interoperability between the software systems within an organization. There's interoperability across organizations. And we talked about some of this earlier in today's conversation even. And the reason we break it down like that is because they all sort of go by the name integration or interoperability, but there's very different concerns at each level. There's different standards in use. There's different data governance concerns that you need to think about. There's different vendors in play. There's different regulations. And so you really have to take a step back and think about the interoperability problem in general terms. But then as you get closer to the implementation, some of these specific differences start to crop up. And it looks like Ernesto has his hand up.
I was about to say exactly the same thing. Ernesto, you want to come back on this point?
So thank you, Drew. This is a question for you. And so I look at the digital health market as obviously one of the newest, and so you have a lot of emerging and smaller companies pushing their product to the market, and so and of course, because they're not talking to each other, because they're all trying to compete with each other, perhaps it's a function of how young the market is, and I wonder if you think that in 50 years from now there's going to be a lot of merger and acquisition of these companies into kind of larger digital health companies, and so big digital health will become a thing where then it'll be the company's responsibility to start then integrating all of these applications into a solution that's a little bit more interoperable.
I'm actually seeing this. I've seen this with a couple of groups that I'm aware of working across different markets, where you've got venture capitalists and investors buying up individual SME digital health companies with the intention of putting them under one roof and making them interoperable. So I think that's an example of the kind of thing that you're talking about. Drew, is that something that you're seeing? Is that something you're aware of?
Yeah, I mean, the industry is cyclical, and one direction of the cycle is we start bundling functionality into bigger and bigger applications. And we saw that in the US with the EMR movement. Electronic health records were widely deployed starting in about 2008 when funding made that an imperative. And, hospitals spent a lot of money implementing electronic medical records and trying to get as much of their workflow into that single system as possible. Now that that's effectively done, electronic health records are implemented and starting to become optimized. We're starting to see the places where they don't do everything perfectly, and that opens up opportunities to unbundle that piece of the problem and create a digital health company around it. And so there'll be a period of time when this unbundling process occurs, and it's inevitable that we'll start to see some of these digital health inventions overlapping or duplicating each other's functionality, and then it'll be time to bundle it again into a new type of a new type of offering, and this happens on different timescales. So it's hard to say that at a certain time the trend will reverse. We're going to see it starting to take off in a very uneven fashion. It sounds like you're seeing it in some places. There's probably other places that it's still a ways off. We're definitely seeing it though.
There's another really interesting point actually that Ernesto raised, which unfortunately we're not going to have time to debate in any detail, which is a shame, which is the immaturity of the marketplace and the fact that that digital health is still, in spite of the fact that Hal invented it in 1961. Did I hear that right? Maybe I didn't. But in spite of the fact that it's really only exploded in the last 10 years. And what we haven't discussed today, and perhaps we can come back to at some point in the future, is the regulation of digital health. Because that's another point that really we haven't even really started to grasp that particular nettle. How do we regulate digital apps to make sure that they are all right and they are all effective? Unfortunately, don't have time for that one right now because we have two more brilliant speakers we need to hear from. And Bjorn, I want to come to you next. We deliberately there looked at the UK and its digital health model at one end of that healthcare payer spectrum and the US at the other. Where does Sweden fit in?
I think Sweden is quite similar to the UK. We are more of a almost said plan economy when it comes to healthcare. So there's a lot of private players, but still very tightly controlled by the government. And we are in a phase of consolidation and facing issues of interoperability because we got 21 regions and we used to have 10 completely different systems. And now when we, for example, are moving to the highly specialized care is centralized to a few university hospitals. So the patients are moving around much more than before. So we need to make sure that the data comes along in a safe way. So the interoperability is a top topic, which is on top of everybody's agenda. Now, when we are, as Gonicare, when we are out giving consultancy advice to other countries, we tell them not to do what we did, because in this change, 17 of the 21 regions, they went for one system, which was considered best in show. The second and the third largest metropolis areas, they went together for another system. And the capital, Stockholm, they are going for best in breed instead. So they're going to do pick and match from the best components of some of the biggest systems. So we are doing, it's going to be a challenge to get everything integrated. And at the same time, the European Union is pushing for interoperability. So we are working very closely. It's all aspects of patient information and digital subscriptions, for prescriptions, for example, going all over Europe. And I see on a day-to-day basis the challenges of, because they're all the benefits you get with the digitalization. And then there are all the rules coming with it for patient safety and GDPR, etc. And I see, for example, we work a lot with Iceland. We handled their pediatric heart surgery here at our university hospital in Lund, and also the stem cell transplants. And on the practical level, there's a lot of concern. How do we transfer data between countries in a safe way and following all the rules? So in fact, one of the physicians, he's part-time working here and part-time there. So he travels with a hard disk with the patient data, which is, this is 2023.
What's a hard disk?
Oh, well, a hard drive.
USB.
Sorry for my English, but
well, either way, physical media is just, we don't even think about physical media anymore.
Yeah, but and it's so frustrating to see the realities of data sharing when it comes to different systems and different rules, etc. And if, for example, when you have a manual system like that, if that guy is not traveling for 2 weeks, some CTs or MR documents are not being transferred to the physician in the right time, etc. So that kind of challenges are there. To mention some other topics as well, we are looking a lot at the triage to automate that with AI. That's going to be required because as we talk about workforce with the shortages, there's a lot of need to get better triage, getting the right care quickly, because not getting the right care quickly will also get additional need for care. So I'm not losing people in the system, because that's happening, unfortunately, as well, because we don't have, in the old days, you stayed in the same village and you had the same doctor. Now, when you're seeing new doctors and new nurses all the time, the system has to keep track of you, and you can't lose somebody, because some people are just sitting at home waiting for being called for the next procedure. And if the system doesn't work efficiently, well, you face some dangers. And then the final thing I want to mention is we have in Sweden already today probably one of the fewest in the developed world, one of the fewest number of inpatient beds in the world. And we're even reducing that. And there's a huge pressure for what we call close care or patient-centered care, where you can get even advanced care in your home. So that brings back to the discussion in the UK about whether to invest in new hospitals and the buildings, the bricks and mortars, or whether you need, because it's a completely new way of forming the IT structure to support not just the schedule of the nurses and physicians who need to be in different places for treating different people, to get the right assets and also to ensure the data gets to the right people. So that's a huge transformation, moving from the big super mega medical cities, which of course are needed for some highly specialized care still, but a lot of the care needs to be much closer to the patient, and the patient shouldn't need to move.
I mean, it's a really interesting point that you raised, particularly around the use of AI for triage. You know, if you want to talk about one thing that in the future, we're not there yet, could actually mitigate the need for people to actually have that intervention-based piece that Hal talked about at the very beginning, the actual sitting down with a doctor, the number of people. I remember doing a piece years ago about how the development of a digital front door would affect hospital overcrowding. You think they're at opposite ends of the spectrum, right? But at the end of the day, hospital overcrowding is mitigated by good primary care. Good primary care catches things that can be treated using medication, using exercise regimes, diverting people towards mental health, diverting people towards social care where required, and reduces the demand on the acute care system. The problem then is that, you know, there's a great thing that in business you never actually solve a problem, you just move the constraints. What you're doing is moving the constraint from the acute care setting to the primary care setting. What then happens when the primary care setting becomes overused, becomes overcapacity? Well, actually, that's where digital health potentially, with the rise of AI-based diagnosis, could potentially solve the problems. That's a really, really interesting point. Gonna have to move on. We are running short of time. Phil Anderton has sat for an hour and a half patiently waiting for his turn to speak. And it's a really interesting one, because actually I think it relates to this point around virtual care and the delivery of virtual care, because nowhere is that more necessary, I think, than in your area, Phil, in mental health. It's an interesting one, this, because I think that we've talked about this from a broad geographical point of view. Let's talk about one specific area of treatment. Phil, how will digital health change the way in which we deliver mental health care? And there's always somebody who forgets to press their mute button before they start speaking, isn't there? Phil, we can't hear you.
There we go. Yeah, wow, $1 million question there, Steve. I think everything that's been discussed there, if we track right back through the whole meeting, big data, the use of data to get information, live data, real data coming from the individual, push and pull, you know, and how can that revolutionize mental health care? Of course it can revolutionize it. But I think one of the greatest things we've got to acknowledge is we've got to have digital thinking to enable digital healthcare. And I've listened to all of those speakers, great conference. What everyone's outlined to me is we've still got a strong influence of analog thinking, trying to bring in a digital world. And we've got to actually start thinking about things differently so we can enable the digital world in its complete format. You know, one of the things that I think we've got to recognise is, say, let's take within mental health, what is it that we're trying to achieve as a healthcare provider in the digital world, and then how can we digitize that? Because if we still try and deliver everything that we have done in the analog days, we're not going to be able to digitize it, and we're not going to be able to make it commercially viable. We're not going to be able to get those regulatory frameworks. We're not going to get interoperability. We're not going to get those things into place if we think about it from the analog days. So we've got to start thinking about what is the digital problem that we're trying to solve healthcare-wise first, move into digital thinking to reframe what it is and what it can do. And I think we'll get stuck. And I hear that in all of the speakers. We're going to get stuck if we carry on thinking in an analog way without moving before we move into the digital world. You know, we mentioned GDPR. GDPR is amazing. We've talked about and Hal talked about the sensitivity of personal data, and yet we have to share data to actually get information. We have to get information to get to a necessary set of actions. But we're trying to determine what is a safe way of transferring data from an analog perspective, not from a digital perspective. And then Bjorn's saying there that the best they've got at the moment, because of constraints and restrictions into country, is a guy on a plane with a hard disk in his rucksack. That's a fantastic solution to an analog way of thinking about a digital problem, and we've got to actually work out what it is. So working out what we want to do, I think, is the strategic decision before we work out how to digitize it. You know, take for instance, we talk about the NHS and we talk about American having a health market. If we just look locally for 1 second, what is it we're going to want the NHS to do in 10 years? And then let's digitize the bits that are relevant for the NHS, and let's digitize the bits that are going to be relevant for the private sector supporting that national provision. And let's not try and think about doing everything the way that we've always done it, because we'll always get what we always got. And that's going to be the biggest constraint to digital progress. We've got to actually rip up the rule book and start again with a digital rule book, not an analog rule book. You go into any hospital, and I go into many across the UK, we've still got paper records lying about on cupboards. We've still got paper records on files. Now, they don't suit a GDPR way of working, and yet GDPR is being crushed by, or is crushing, the exchange of information effectively. So we've got to rethink, where are the new safety parameters? What would be the new protocol? What would be the new way of working this out in a digital world? Not trying to shoehorn digital into analog processes, I think, is the strategic imperative.
Fascinating insight, Phil. Love that. I'm gutted to say that we're out of time. That's an hour and a half that went by in about 20 seconds. I wish I could hear more from all of you. We could go on for another hour and a half. It just remains to thank everybody. Thank Ernesto, Drew for giving those perspectives on the US, Bjorn for hard disks on aeroplanes in Sweden. Vincent for that insight, Vincent and Phil really for that insight into the UK, and Mwenya for that brilliant précis of some of those challenges in Africa. It's been really fascinating. My name's Steve Gardner. I'm the Managing Director of Healthcare World. I'll be at HIMSS in a couple of weeks. So will Hal Wolf, the President of HIMSS. Hal, bit of a joke question to finish on. I jokingly referred to this when I was introducing the panel as being the World Cup of Digital Health. Who wins the World Cup of Digital Health? Where is the best example right now of digital healthcare in action globally? Not that that's in any way an impossible question to answer.
It's not, and I'll give the answer at your panel in Chicago on Wednesday. Is that a good lead-in?
That's a perfect lead-in, Tom.
Steve, I just want to say thank you. I learned a lot. I thought that the communications and what the collective of this was just a fantastic experience. Thank you so much for having me.
No, and thank you to all of my panel, and thank you to everybody who's been watching today. Been a really, really great session. Come back soon for the next Healthcare World Series, and we'll see you in Chicago if you're there.